Welcome to the podcast on interdisciplinary teams for older adults with complex care needs. This podcast was created by Melissa Aslagi at the University of North Carolina, Wilmington School of Nursing. It's based on content authored by Dr. Sharon Stahl-Wexler and Dr. Jeannie Siegler. It will be presented today in a dialogue with Dr. Sharon Stahl-Wexler and Dr. Catherine D'Amico. We'll begin by letting them introduce themselves. Dr. Wexler?
Okay, I've been involved in care for geriatric patients pretty much my entire career across the continuum of care, in acute care, long-term care, and home care. I'm presently Director of Nursing Research and Evidence-Based Practice at New York Hospital Queens in Flushing, New York, as well as a Clinical Assistant Professor at NYU College of Nursing.
Okay, and Dr. D'Amico?
I'm Catherine D'Amico, and I am presently an Assistant Professor of Nursing at Hunter College in the city, which is part of the City University of New York. And I have been caring for older adults, mostly in acute care, since the late 1980s.
Our objectives are to identify the necessary components and roles of an effective geriatric team, to identify issues of management and important health-related outcomes, to identify the quality indicators for effective geriatric teams and elements of team cohesiveness, to review facility protocols to determine the interprofessional nature of the care setting and roles of team members, to critique models of geriatric nursing in hospitals, home care, and long-term care settings.
If this is important because the care of older adults, because they have many interrelated problems, is complex. And so it's important that we move forward with working with other healthcare disciplines who have expertise in areas that nurses do not, and for nurses to provide their expertise to those individuals who are from other health disciplines who need the input from the nurse who is typically the person who is at the bedside most frequently with that older adult.
I think that interdisciplinary teams, as we've just said, are very often used to manage older adults across the continuum of care, and particularly older adults that have complex healthcare needs, particularly older adults who have some of the geriatric syndromes such as falls, pressure ulcers, urinary incontinence, or polypharmacy. All syndromes which are complex, have many different facets to them, and really require the expertise of many different professionals.
And the teams are not always equivalent. Frequently, there are people who come in and out of the teams. For instance, a team that's caring for an older adult who may have the syndromes associated with falls or pressure ulcers might include a physical therapist or an occupational therapist, but a team that's talking about a patient with incontinence as a geriatric syndrome may not have that person on that team. So the teams may have different people who come in and out, but those people offer different levels of expertise as are necessary in terms of the team. The teams don't always function as well as we would ideally like to see a team function, and I think that teams evolve and some people work better with others, but there always needs to be somebody who makes the effort to make the team function and focus for the good care and the excellent care of our patients.
I think another important thing to note is, although we don't always want to focus on regulatory requirements as a reason for delivering care in a specific area, it's important to note that many of our regulatory requirements related to care of older adults do mandate teams. For example, the Joint Commission, in their latest accreditation manual for hospitals, speaks of the need of having interdisciplinary team discharge planning and a documentation of an interdisciplinary process. In the long-term care setting, the whole process of the minimum data set, the MDS process, which is required for reimbursement and really drives a care planning process in long-term care, requires an interdisciplinary team process. The home care setting has always used an interdisciplinary process. So although I don't like to think of that as the reason for interdisciplinary team process, I think it gives the whole the knowledge of what an interdisciplinary team is and how it functions even more importance. the amount of different expertise and help you need when you're dealing with complex patients. It relieves the burden on a nurse for having to figure out all the different things. For example, my area of interest might be function, and I might be very interested and have a lot of resources when it comes to maintaining functional status. I know about geriatric pharmacology. It's much more effective to have a geriatric PharmD on a team that can zip through the meds and look at it and say, gee, your problem with function could be due to the interaction of this med, and this med. So I think that's really important. I think they offer greater objectivity. Caring for an older adult that has a lot of issues, very often we're looking at something from one perspective. We're, for example, looking at a patient who falls a lot and doesn't seem to be as compliant as we might think the patient should be, and we just don't understand why they keep falling. I had an instance like that recently, and it was a physical therapist that was able to help us, focus on the fact that, okay, he falls. He's not going to follow your directions to ring a call light. Let's instead look how we can tailor the environment to prevent future falls. So it added a different perspective that, thinking back, I knew I should have been thinking about, but I was so wrapped up in figuring out why I couldn't get this patient to ring the call bell, that here it took somebody saying, okay, fine, let's stop worrying about call bell. Let's not think about bed exit alarms. Let's think about what else you can do to fix the environment so the patient doesn't have any more falls.
I think that brings up the point, too, that Sharon and I have both made when we've used this module to provide education to educators, is that everyone needs to know what is the role of each of those other providers. You need to know what they contribute, who to call, in terms of how they contribute to the group. We know that the physical therapist contributes information in regard to how the person can walk, what kinds of things we can do in terms of preventing falls. Social workers contribute something different. The pharmacist contributes some other information. It's probably important for students as they go through this piece to try to learn what are some of those other roles and what do those people in those roles provide.
I can give a recent example. I had students in a clinical setting. There was an opportunity for a student who was shadowing a staff nurse to go to a meeting, and the focus of the meeting was performance improvement process, looking at what was causing an increase in post-op pneumonias in older patients. And the student attended the meeting and came back, and I had her share her experiences in a post-conference, and she was very impressed by all the different people who were at the meeting. There was a physical therapist, there were physicians, nurses, social workers, there were surgeons, there was a pulmonary doctor, there was a speech-language therapist, etc. And the student said to me, I said, what are your impressions? The first impression that she shared was she was impressed by how much nursing had to give to the team, that they really were able to address, she said, so many different things. It wasn't just, the nurse was able to address, did the patient take their medications, what the patient's mental status was, what their functional status was. She also made a comment that the nurse's opinion was really well respected. And then she said to me, she was the only person I couldn't figure out what they were doing there was the speech-language pathologist. She says, because I don't understand what that has to do with pneumonia. And we started to talk as a group, and when I went around the group and I asked everyone, what do you think a speech-language pathologist does? And they're like, well, if somebody's had, and they said, well, when children are learning to talk and they're having problems, I said, okay, but let's think in an older adult population. Well, I guess if somebody had a stroke and was having trouble talking, and I realized that was probably the only experience that they had dealing with a speech-language pathologist. Now, myself, as a geriatric nurse, I knew right away, okay, post-operative pneumonia, maybe we're looking at aspiration pneumonia, and a speech-language pathologist can evaluate swallowing and make some suggestions to prevent aspiration pneumonia. And when I shared that with the students, they were like, oh, wow, we didn't know that that's what a speech-language pathologist did. And I thought they only taught people how to speak when they were having difficulty learning or had some alterations in speech. And then I realized that very often we take for granted that we understand all the different functions of the different team members. I think one important thing is that not every patient and every patient care situation needs a team. There are certain things that are, I guess, that are handled better and more expeditiously and more time efficiently by one person who has the knowledge, time, and expertise to do the task independently.
The nurse is probably the one that decides how many team members need to be involved. If we're coordinating that care, we're going to have to call, the social worker
Correct.
or the physician or the urologist or the physical therapy to get them involved to bring in their expertise, versus there are formal times where meetings are set
Correct,
with the
correct.
team. So it happens, it's not always just a set formal meeting, it's the day-to-day task. So you will do this pretty naturally as part
Correct.
of completing your job.
Correct, and even in some of the more formal situations, some of the geriatric care models that we're going to talk about, the acute care for the elderly model or the geriatric resource nurse model, it is the registered nurse, the RN, that's leading the team and very often making the decisions of who she's calling in or who she's including as part of the interdisciplinary team.
It's important, in order for the team to be effective, that we call in the people that we do see as having the kind of expertise that we need. One of the very important pieces about the team and the team's work is their ability to communicate effectively. We really do have to be careful that we actively listen to others, and that we are paying attention, and that we are responding back in a manner which supports everyone's role as part of the team. We may sometimes need to seek clarification, to make sure that we understand what that person believes is the thing that's going to help this older adult. And there are lots of times, as Sharon described earlier, with the physical therapist who's saying to the nursing staff, you're not going to get this person to ring the bell before he gives up, so we have to look at another way. That's a time when someone else, but it could be the nurse, thinks out of the box and says, the normal ways to fix this aren't going to be the ways to fix it. We have to do something different.
We already spoke a little bit about how the RN may be the best person to bring the direct care provider aspect to the team. The RN very often has the best assessment as to the patient's functional and mental status. The advanced practice nurse, the RN or the clinical specialist, brings those skills but also brings additional skills to the health assessment of the older adult, such as health promotion, ordering, conducting and interpreting diagnostic testing data, clinical management, and an education piece. Although there's a lot of work, we by gut instinct know that interdisciplinary teams are the way to go in caring for older adults. When you look for empiric evidence-based research about specific contribution of teams, the evidence is growing, but in some areas there's not a lot. Studies as to team effectiveness are sometimes very difficult to conduct due to the many variables involved, the increasing complexity of older adults, inconsistent terminology used to describe terms, really figuring out when you're looking at older adults who are benefiting by team care, what aspect of the team, whether it's the interdisciplinary team, the team approach itself that's contributing good care, whether it's the multiplicity of services offered that's making care good, whether it's just the collaboration and communication among all the different providers. It's sometimes very difficult to figure out which of all those individual things together are making for good outcomes for patients, or whether it's the interaction of those things. So doing specific research on the team aspects is a little bit difficult. There is strong evidence supporting interdisciplinary team effectiveness in acute care, subacute care, particularly rehab settings, as well as home care, particularly in specific diagnoses or syndromes such as hip fracture and delirium. The evidence is a little less strong on the impact of team effectiveness for older people related to depression, dementia, and palliative care. However, there is growing evidence that the geriatric models of care, which do involve teams, do improve patient care outcomes.
Okay, well, in the Geriatric Resources podcast, we talked about some of these models of care and just introduced those concepts. So maybe you could take the time to explain the models of care a little bit better for baccalaureate students.
The first one, just a little bit more on the acute care for the elderly unit, the ACE model of care. And the ACE model of care is one model of care that has demonstrated positive outcomes of interdisciplinary teams for older adults. And if you look at the ACE model, one of the distinguishing features of an ACE unit is interdisciplinary collaboration. Other features are making the unit elder-friendly with environmental adaptations for older adults, such as enhanced lighting, different flooring, furniture, beds that go low to the ground, bed exit alarms, etc. Nursing staff and ancillary staff that have received special expertise in care of older adults, a patient-centered focus, and I think that really can be translated into the patients come first. So, for example, most ACE units don't have designated visiting hours. Visiting hours are whatever the patient wants as far as patients and family and friends to be there with them. They very often don't have set times. Some units have set time. Regular medical units will have set times, for example, for when patients get bathed or when vital signs are taken. Most ACE units don't have that. It's tailored to the individual needs for the patients. There is generally strong evidence that ACE units improve short-term functional outcomes for the inpatients that they care for.
Geriatric resource nurse is another model that's used in facilities where, especially in acute care, where we cannot have an expert geriatric nurse on every floor who's an advanced practice nurse. In order to extend that advanced practice nurse, the geriatric resource nurse is a staff nurse, a primary nurse, who gets additional education, who becomes the nurse who is the resource, the go-to person for problems associated with older adults on a regular medical surgical unit, on a rehab unit. And so that nurse helps to identify team members that will help and involves the geriatric advanced practice nurse and involves the staff nurses on that unit as necessary with a patient who has particular problems related to geriatric syndromes and things like functional decline. So the geriatric resource nurse model is a model that sometimes works well because it helps people advance on a clinical ladder. It provides a clinical ladder way for certain acute care institutions, but it's also a way for the nurse to increase her expertise and make some decisions about whether or not they want to move forward with further education.
So a geriatric resource nurse would be a team member that a staff bedside nurse could call upon, resource person, to help figure out how to best manage this person's care to have the best outcome.
The other thing you could relate it to is the advent of rapid response teams. This geriatric resource nurse becomes the rapid response person for the geriatric problem. So instead of trying to figure out when you could really see the advanced practice nurse who may be the one advanced practice nurse for geriatrics in a 400-bed hospital, this geriatric resource nurse is probably available on your unit or even an adjacent unit, so that person really only has 40 beds to worry about or 50 beds to worry about, so that person is much more available than the person who has to worry about whether or not they can help out with 400 beds.
So as experts in interdisciplinary care, do you have an example that might kind of help frame this process for a new graduate baccalaureate nursing nurse?
Okay, why don't we consider this situation? You're a staff nurse on a medical surgical unit, and you're concerned because you've learned as a nursing student, baccalaureate nursing student, you learned that restraints were not a good intervention for older adults, and you come to work on this unit and you notice that there are a large number of physical restraints used on this unit. You share this concern with your nurse manager, and shortly afterwards your nurse manager asks you to create a CQI team, a continuous quality improvement initiative, to investigate and reduce restraint usage.
So you might want to know who should be on this committee, why do you want these people on the committee, who's going to lead the committee, and how will you manage this committee? Because you're going to need to figure out who can provide you expertise to assist in identifying how to reduce the restraint use and how to educate others on the reduction of the restraint use.
The first thing to do is look at what type of problem you're addressing. You're not addressing an individual patient problem, you're addressing a systems problem. It's not one individual patient that you've seen that's restrained. You've noted multiple patients restrained. So the first thing you're to realize is you're addressing a systems issue. So when you look at the committee, I think you need to think globally who is involved in addressing a systems issue. So I would consider, obviously, nursing. I would consider internal medicine. Let's assume this is on a medical unit. Internal medicine, the physicians are ordering. The restraints require orders. Physicians are ordering them. I would consider pharmacy, because perhaps when you're looking at why patients are restrained, if you're looking at behavior issues, very important to look at what medications your patients are on. I would consider including psychiatric or psychological services. I also would look at physical and occupational therapy.
The physical environment may be something else that needs to be looked at in terms of things in the physical environment that may produce behaviors in patients that may make that patient, may make the patient seem more agitated, so therefore more likely to need restraints.
When you're looking at nursing involvement in this, I think you need representation from all levels of nursing. So it's just not the registered nurses. I think you need the nursing staff, nurse managers, nursing assistants, as well as nursing administrators.
This is a piece, too, where you really need to look at what is the overall evidence. Some of the things that someone is going to battle in this case is that people believe that they place patients in restraints because the restraints protect the patients. The evidence says the contrary. The evidence says that when we give people physical restraints, they are more likely to be injured as a result of the restraints and complications that happen during a fall related to restraints. So sometimes people think that putting people in restraints is a safety issue. So the nurse who puts together a committee to look at this kind of a system issue really has to go back and do literature search and look at what the evidence is that says that restraint use is not helpful.
Right, and through several of these podcasts, we've pointed students to specific resources of where you find the evidence to support whatever argument you're going to make. Because I think anytime you're trying to present a change, you have to put it into writing and then justify your rationale, and that's why students are taught to do those literature searches and to create evidence-based care plans.
This is a place where certainly this would be a time when students could use the Hartford websites and consult GeriRM. This would be a place to start your search because there would be some articles there to talk about falls and to talk about restraint reduction, and then they could continue their literature search from there.
The other thing to consider when getting this committee up and running is who should lead the committee.
Yes, and this is a point where you may want to partner with someone potentially from medicine, because this may be the way to go about convincing medical staff, particularly medical staff who are in their postgraduate years through the help of an attending physician, that every patient who's removing an IV, removing their nasogastric tube doesn't need to be restrained. There are other ways to handle the issue.
And I think you also have to consider how should the committee be managed. I think it's helpful sometimes to realize that in this case we're not addressing a specific patient, we're addressing much more of a systems issue, and to remain focused on that. Because it's very easy to get sidetracked on, oh, that patient, Mrs. Jones, she was only restrained for a short time, and it was for this, that, and the next thing, versus focusing on the much broader issue of restraint usage.
And going back and gathering that assessment data probably at the beginning to say how many
Right.
patients have been restrained so that you have objective
Right.
data
And,
to present.
and also I would suggest collecting that data at various times through your project. It's sometimes when you're working on one of these quality improvement projects, it doesn't seem like you're making much headway. You're expending what seems to a tremendous amount of time and not making much headway. So being able to go back and collect data at a midway point and be able to celebrate the success no matter how little or big it is, and then going back at the end and being able to celebrate success very often is what takes this project, and instead of it being, oh, a nice little project that nursing did, it then brings it back to a systems level, and everyone's like, wait a minute, we solved a really important problem.
As a team.
As a team.
As a team.
And I think sometimes it's helpful to look at one or two units initially and how it's working on 1 or 2 units to demonstrate that if those units have been successful before it gets moved out to a whole situation. Sharon and I worked in a situation where falls reduction was addressed this way. 2 units were the pilots for what needed to happen in order to reduce the falls, and after those units were successful in reducing their falls, then those strategies for falls reduction were actually rolled out to the rest of the institution.
Interdisciplinary teams have been shown to be important in maximizing positive outcomes for older patients across the continuum of care. They offer added value to the assessment and management of older adults with complex illness, and they are applicable to all care settings where there are older adults.
It's important to understand the team process, the roles of the team members, which we described earlier, or to investigate what those roles are for the team members versus when it's suitable to work alone or in a smaller group.
Well, that concludes our time with Dr. Wexler and Dr. Amico, and I would like to thank them both for sharing this insightful conversation about interdisciplinary care teams and how they're used across care settings for older adults.